بالظبط.
افتح باب بس وهتلاقي ناس بتخبط، يعني حاجه افتح
بالظبط
باب يعني حاجه سهله، وهي الناس تحب تشارك وتحب، يعني الواحد بيتعلم وبيشارك اللي عنده مع الناس التانيه، فبتبقى فرصه كويسه للجميع.
الحمد لله يا فندم.
الحمد
نشرف
لله.
بوجود حضرتك يا فندم.
لا انا اللي
سعادتك
سعيد
تحب
جدا
نتراي
بوجودي معاكم.
اللينك كده، نتراي شيرنج سكرين قبل ما نبدا؟
طيب شير سكرين.
جميل جميل اوكي. طيب جميل. خليها يا فندم، مفيش مشكله يا فندم. احنا
ممكن نخليها كده دلوقتي.
يا فندم we have just 1 minute to start.
ما
لان
فيش
الزملاء
مشاكل
بيبداوا يجوين على
محمد.
الساعه 9 بالظبط ان شاء الله.
طب انا اقول لحضرتك، هو حضرتك هتحب البروجرام هيمشي ازاي؟ يعني هتبقى المحاضره وبعدين
If we have any questions to you sir, you can read it or I can read it to you.
اوكي
after the presentation sir.
خلاص، يبقى بعد اذن حضرتك، يعني النقطه ان انا هقول البرزنتيشن، وبعد كده انا سايب في حاله كده في الاخر كده مثلا كلمتين صغيرين كده، جاست ان هو ايه to tease the people a little bit، يعني هي بس كده حاجه في الاخر. وبعد كده زي ما حضرتك بتقول لو حد عنده اي اسئله او اي حاجه ممكن نخليها في الاخر.
At the end of the presentation sir, we can open the chat and the questions and answers for our attendees, our dear colleagues. So if they have any comments or any suggestions, they can put it on the chat. Okay?
Absolutely. And even after we finish whatever is related to the presentation, I'm more than happy if people has got any inquiries, any questions in general, I'm more than happy to be available and try to answer.
Okay. شكرا جزيلا يا فندم. We are ready to start. بسم الله الرحمن الرحيم. طبعا يسعدنا ويشرفنا ان يكون معانا النهارده يعني اخ عزيز فاضل من يعني اخواتنا المصريين الطيور المهاجره في الخارج، دكتور عمرو حسين، orthopedic consultant in Scotland. دكتور عمرو يعني مشكورا he accepted to join his experience to our dear attendees and dear colleagues. احنا بنستاذن حضرتك دكتور عمرو بيه، هو المحاضره بتبقى ريكوردد واحنا بننزلها على اليوتيوب شانل، لو تسمح لنا يعني بعد
اكيد دكتور
بحيث
محمد،
الاستفاده تبقى للكل يا فندم. احنا سعداء بتشريف حضرتك معانا يا فندم. Professor Amr will speak about a very important topic, periprosthetic fractures around the hip. Thank you so much for joining us, sir.
Thank you, Dr. Muhammad. First of all, salamu alaikum. I'm really honored and pleasure to be with you guys with this very generous invitation from Dr. Muhammad to share together some of the subjects that we go through together. So just a quick brief. I'm an Alexandria University graduate, and then I worked in Egypt, Saudi, and then I came to England, had my training mainly there, and ended up having a consultant post in Scotland. And my subspecialty is trauma and arthroplasty, lower limb arthroplasty, hips and knees. And that's why, hence, the subject I chose to start with is the periprosthetic fractures around the hip, which would be mainly the ones around the femur. So just a quick glimpse. This is the hospital I work in, and this is where it is on the map. It's quite up north. So just as you see west of Glasgow. And these are the two main sites I work in. The one on the left is the main hospital I will do my elective work in. So disclosure, I don't have any relative disclosures to the subject. So now to total hip replacements. Well, total hip replacement is the surgery of the century, actually, and it's labeled as the second most successful surgery in medicine, next to only cataract. In the UK, well, it's about 80,000 hips are done every year, and in the NGR, which we collect the data, from 2004, we have more than 125 million hips done in the UK. As for periprosthetic fractures, from the register as well, we know from the English and the Swedish register, we know it's the third more common reason for revision after aseptic loosening and dislocations. So incidence, different reports about the incidence of this injury. It can happen intraoperative or post-operative. The biggest cohort found was coming from Mayo Clinic. And as we can see, intraoperative uncemented has got about 3%. And as we can see, it's the significant 12% in the cases of revision. That's the rate we can have in periprosthetic fractures on table. As for post-operative, again, different variation between cemented, uncemented, as well between primary and revisions. So it's worth always mentioning that most of these fractures happen around the femur, and the ones regarding the acetabulum, usually they happen intraoperative. It's not common to happen post-operative regarding the acetabulum. Still, it can happen though. So is it an important injury? Well, we can see this is just, well, two recent studies, one of them showing the mortality of such a periprosthetic fracture around the femur. Mortality in 30 days, about 3%, and 1 year, it reached about 14%. And again, just to put this into context regarding the other things around, whether if it was a primary total hip, it's just about 3%. This is 11, and a fractured neck of femur, which normally had a high rate, is about 16.5%. So it is important to deal with. So another thing is the impact. Actually, this is a complex injury, and actually it is not easy to deal with, not from the expertise, and it is an expensive procedure. So just a quick survey, we can see between England and Europe in general, we can see that usually it ranges between 15 and 30,000 pounds to deal with such patients. And two studies were interesting that they showed, they break down these figures, and actually hospital stay, it carries about more than half of the expense of such injuries. So these patients, they stay in the hospital for a long time, whether from the injury, because they are frail, but they stay with us for some time. Risk factors. Few risk factors are out there, but the ones, some I divided into patient-related. So some of them, female, old age, osteoporosis, and rheumatoid arthritis. These are, well, many studies showed these ones has direct relation. And related to the surgery itself, uncemented implants, well, it's obvious that everyone knows that uncemented implants definitely carry a higher risk, and revision surgery as well. There's a high risk with revision surgery. Osteolysis can be, well, the reason why we went into this at the beginning. Minimal invasive approaches, well, though it's nice to do through minimal invasive, but if things are stiff, well, this can easily break the femur. And regarding the acetabulum, usually, like we said, it happened during the during impaction of the acetabulum itself, and usually it happened because of under-reaming more than 2 millimeters. We can put it either with press fit or line to line, but on more than 2 millimeters less, they can cause the injury. And for the femur, well, again, long stems mismatch with the femoral bone. Just a small, I wanted just, sorry. So this is just a small thing about the acetabulum thing. There are new cups now, they come as elliptical cups, not the normal hemispherical. And these ones has got peripheral expansion. So if you're gonna put in a 52 cup, for example, you don't ream just 52 with these peripheral expansion ones. You might need to ream the periphery, maybe 53 or even sometimes 54. So something just to be aware of with this new elliptical, or well, for example, PSL and the strikers, elliptical ones, they have peripheral expansion. And then treatment, well, assessment. As we said, we should have high index of suspicion. During the surgery itself, you're doing the cup and suddenly there's a give. You're putting the femur in, and again, you felt unexplained give. So we should just wait a second, reassess, and check whether there's any cracks happening on the acetabulum or the femoral side. Post-operative, well, most of these injuries actually, again, because happen to frail people, so it's a low energy trauma, just a fall from a height. It doesn't have to be a big accident or a big trauma. And it's very important in the assessment to know about how the index procedure or the implant that was there. How was it? Any signs, any problems happened before, after surgery, or just recent? It's very important. And again, part of the assessment, we need to have a full length of the femur, and CT is often very helpful just to assess the extent of the injury. It can tell us about indirectly the stability of the stem and what example cement mantle as well. And with the assessment, again, always don't forget infection. So classification. Well, we are fond of classification in medicine, especially in orthopedics, but I have to say very few classifications we use on daily basis, and this is one of them. So the Vancouver classification by Duncan and Masri, well, from Canada, 1995, had, this is the very famous division between A, B, C, A, which is GTLT, B around the femur, B1, which will be just a fracture, good bone stock, the implant is stable. B2, the good bone stock, implant is not stable. B3, bad bone stock, implant is not stable. And C, as we can see, it's distant to the implant. And we'll say distant if this patient, if the cement is a cemented one, it has to be beyond the cement restrictor at the end. So classification again. So this was just quite an interesting study by Karam in 2020. It just shows the prevalence of these injuries. It turned out that in general, type B fractures in general are the most common ones. And within B, even that B2 is the most common, according to Karam, the most common periprosthetic fractures around the femur. Well, thank God B3 is very little because they are not great in management. Again, well, like I said, we're happy with classification. Coventry had a nice, well, they called it classification. I would rather label it just how to prescribe the stem, happy, unhappy. I just tend to find it sometimes very easy when we're trying to talk about the implant that was there, take the history, and at the end, was it a happy or an unhappy stem? So very clear. Well, you can roughly see when you look at this one, it looks like a good stem. Compared to this one, I think something was going on there even beforehand. So there's a difference between these two implants. And there's a very new one by Duncan, who did the Vancouver one with Prof. Haddad from London in 2014. They made a new classification. I tend to find a little bit complex. They put together bones like the AO, bit of a Vancouver with the loosening. So they just mixed everything. Tend to find it more towards research and communication rather than really management patient on day-to-day basis. So treatment. Well, I think one of the main aims of such injuries, despite being very challenging, early patient mobilization. These patients, they do not great if they stay in bed. Well, they don't do well. So, and to achieve this, we need to get good anatomical reduction, good stable implant. We need to have bone stock. These are all to achieve this. And we need the fracture to unite, and we need the joint to be functioning. Well, I mean, just to get the patient back on their feet. So non-operative treatment for this type of injuries, well, definitely anything can be treated non-operatively if the patient is not fit. Well, we're all aware of that, but it's not something that we choose to treat these patients non-operatively because, like I said, they don't do well. ORIF versus revision. Well, again, revision is more expensive and the ORIF takes less time, less complication, less hospital stay. But again, not everything can be dealt only with ORIF. And maybe just because of this line, when we come to talk about the B2s, though tradition is for revision, some people now are trying to just fix it. Again, just because of the risk between revision and fixing. And again, this is not easy cases. Like I said, there are two things, though not just one, not just a fracture. You've got a fracture, you've got a joint. So you need to be trained both in trauma and arthroplasty, especially revision, before you do. This is not a case you say, I have a fracture, I'm going to fix. No, believe me, it's more complex than that. So planning, very important. That's the main thing to success. I believe it's planning. So you need to have the expertise. You need to have the kit available. And usually, if possible, I would rather have plan A and plan B at least on the shelf, not just go in because things can change. These patients, as we said, by default, they are frail patients. So they need to be optimized beforehand. And there's sometimes significant blood loss. So group and save, cell salvage machine, if they are available, they are all measures that we can do to prevent the blood loss. So, and again, we mentioned reduction. It's all about reduction. So to maintain, to get the function and to get this moving again, you need to have good reduction. And again, loose implants, they move, they cause pain. And again, with movement, less healing. So this is just to share with you just a quick thing about the implants, about this. So these are the three main common ones used for periprosthetic. The one on the left, the NCB from the Zimmer, tend to be even the most common. And I have to say it's my own favorite. It just gives flexibility to do it. And this one and this one, this is a trochanteric one. You can add it on top of this just to add to the trochanter of the plate. And these ones towards the distal one. I just want to mention again, because the one I'm used, I tend to very helpful. These three rows of screws, which we can see they're not found in the axis from Stryker. And if we try to add these flanges a little bit to do the same function. But again, these are the three main things. These are very strong and sturdy plates. The bender to bend these plates is a massive bender that you need pretty much to go with all your weight. These are very sturdy implants. So these are for plates. And again, whatever you have on the shelf. And when we go for revision, these are, again, the common long modular ones that we use. Again, personal preference, I tend to like the Arcus from Zimmer. Gives me more options, plus it's got a locking option distally, which is not with the restoration there. So again, general preference, Arcus would be my option if it's available. So coming back to these injuries, again, one by one, the GT and the A. So how to fix these ones? If they happen intraoperative, these are not the ones to ignore. So these are not the ones you say just even doing a hemiarthroplasty or a total hip. It's not a case to say just leave it there or take it now. It displays, and to be honest, it's one of the biggest nuisance that can happen in hip surgery. So we need to fix it back either with a K-wire and tension band or a plate. So, and if it happened post-operative, well, most of the time you would start conservative first, and if it got displaced, we will need to do something for that. So, for example, like I said, we can mention the K-wire, tension band K-wire, or we can use the small trochanteric plate, or we can use a bigger trochanteric plate. So these are the options that we can use. I know, well, it's used, people can fire 2 screws to fix it there. I'm not quite sure it's strong enough to hold the GT in place. So Vancouver A, lesser troch. Again, the picture here, well, different pictures, and it's very hard to assess what's meant exactly by the lesser troch, because some classification, some pictures will give a bigger chunk even of the LT. So, and that's why I would advise whenever there's a fracture regarding the LT, let's have a CT. It just will give us an idea about how big the chunk is and the extension of the injury itself. So again, so this one, okay, it might look benign, but with a CT, it might seem to be extending. So again, it's assessment. We need to assess, we need to know what we are dealing with before we go in. Vancouver B, we said the implant in this one, the implant will be stable and the bone stock will be good. So pretty much so happy implant, so we just need to fix the fracture. We can fix this one either with cables or with plates. So cables like this one. So, and this is, well, this happened actually even intraoperative, this one. And we can see it can be bigger one and it might need a plate and screws. So again, implant was stable, implant left in, either just cables, small crack, or you can need to go to a full-blown one. B2, so in B2, so the implant itself is unstable now. So whether this is identified beforehand, before we went in, the patient was already complaining, or it was assessed on table and deemed to be unstable. And I have to say, it's a very tricky just to go in and try to assess it on table. It will make big difference in anything, starting from the position, starting from the approach, everything. So if you can try to get information beforehand, before you go in, I would rather have my plan in mind before I operate and have less surprises on table. So how to deal with this? Like I said, because the implant is loose, so ideally it has to be revised, and whether this is just a revision, like example, a long one, or you need to augment this with an ORIF. So two new things are, well, on the merge at the moment. So when we say revision, with the cemented ones, actually some people now would even, instead of having to revise everything with the cement, and we know how hard it can be sometimes taking all the cement out. If the bone cement interface was okay, so the cement can be kept in and we can do a cement in cement revision. This is considering that we managed to get a good reduction from, so get a good reduction outside, bone cement interface is okay, there's no loosening there, then we can take the implant out and then we can do cement in cement. And again, it's a technique that you should be trained on before going ahead and doing it. Oh, and again, and when we mention ORIF, not the ideal situation, but sometimes in very frail patients now, especially that we know how complex the revision can be, some units might opt for intention, just said, I'm just gonna fix it now, knowing it's not ideal, just because of the complication that might happen for this specific patients with revision. So, for example, this is case revised with a cement. So this is just showed one fixed and revised. This with a cement, with uncemented, still well, we can revise the stem and put that's I remember, as far as I remember, I think this was a restoration one. This was a striker restoration one. And this is just how it is. When we see towards the end there, so just again, when we mentioned the mismatch of the bow, so this area here, because it's a modular, so this part here, this can be either straight or curved. Again, depending on how far you need to cross, just know your implant, know the things that you have, and be sure you have what you need. Again, that's another one. So that's the one where we mentioned it's fixed. So these ones ideally, again, with the uncemented, with all this bone and all this cortex disturbed, you would expect maybe some element of instability. So in this case, they opted it was fixed in place and just hope for the best. Well, again, depending on the type of stem that we use, we know that the stems, either it's a distal fit, proximal fit. Again, know your implant, know what you're dealing with. And again, put your plan according to that. B3, the nuisance. Well, the worst one of all of them. It's very challenging. It's very hard to deal with. And it takes a lot of time. So implant is unstable inside and we don't have a good bone stock. So it's revision and ORIF, or either we might need to go for a mega prosthesis. I know classically we tend to put struts, putting struts whether in B2 or in B3. Well, I have to say I couldn't find anything recent now of the use of strut, very, very few. And I have to say in my own practice, I never used it so far, the struts. So let's, for example, these ones, again, these implants are not stable, so revised for a long one, and cables were done. That's even a worse one, as we can see. So more cables and try to put everything back in place, and it can heal. We can see HO happening there, but again, this is in general a complex procedure. Again, another one you could expect with all this loosening there, the bone stock will not be great eventually. So again, another revision with a couple of few cables just to fix it in place. Now, another example, and this is one we mentioned, like a mega prosthesis. This is like a proximal femoral replacement. And what they do, so they get the bone on the side and they just add it to the implant itself and try to cable it around instead of leaving just metal on the muscle. First of all, we just keep in mind that the abductors are attached to the top there. So if you take all the, it's very hard to attach the abductors again. So though some of these implants have got holes and everything to pass stitches through, but no, they don't, unfortunately, they don't do great. They don't stay in, unfortunately. So again, proximal femoral replacement, adding the bone in, putting it around, it can be an option. Vancouver C at the end of the classification, but well, interesting, it's relatively easy one to deal with. It's just, I've got a broken bone I need to fix. Just keep in mind that you've got an implant further up there. So this was a case a few weeks back. So the patient was, I think, about 85 years old, had this injury. So end up cables and fixing the thing. Well, I have to say, in general, I would rather, if possible, span the whole femur with the plate. Just try to avoid stress riser. So if possible, go as far as the GT, as low as the knee. If the area up there, we can just do it as a MIPO technique, if you're okay with that, but leaving it quite short, no, it can cause some serious complications. So just to mention now, we are having some atypical fractures of the femur in general, like the alendronic or the bisphosphonate type of fracture that happen with a primary femur. And we know it's not easy to deal with them. So these can even happen on top of the implant, and it's like an atypical periprosthetic fractures. And I found this report from Japan, actually, and it showed that up to 14% of these patients of this atypical fracture can go to non-union and metal failure. So as we can see, these are all signs that we can try to, so this reaction there at the cortex, and usually the way it snaps. So all these things, this is atypical fractures, and we should just be a bit cautious when we're dealing with them. So they don't unite. So they take very long time. This one, it's very sclerotic there, and it's very challenging actually to get these patients to unite. Well, we all have had these patients, like for a normal fracture that you would say, put a nail in. Actually, I'm tending now even for nails. For these ones, for just one, I would add small plate on the side as well, on top of the nail, because they are very challenging to heal. So this was a case, actually, I did maybe 3 years ago or so. Well, pretty much same thing. It had this atypical injury there. And as we can see, usually it happened on the lateral side and it snaps there. So went up with fixation, the reduction. This is just when I mentioned the NCB plate. This is just shows the 3 rows of screws that we mentioned before. It just allows me to put my screws around the implant, as you can see there, instead of having 1 row. So the 1 row in one of the plate, they have row. Actually, to be honest, they are variable angles. So they are, yes, locking, but with variable angles, 15 to 20 degrees, you can angle it. These ones, I can put in a little bit variable angle. Plus, like I said, because it's on a row, it gives me the access to put my screws around the stem. So what can happen surgically with these patients? So patient had it fixed. What can happen here? Well, as we mentioned, I would rather span this as much as I can. So go as high as you can, bend it towards the end and fire some screws. Instead of having this fixation, it will cause stress riser and failure of the construct. Again, a short one, fracture, which end up doing what was meant to be done from the start, a longer plate just to cover everything and span the whole femur. Again, the plate can snap. So yes, they are very strong plates, but let's keep in mind, it's always a race between healing and failure of the metal. No metal can stay in holding our weight forever. So it's just, we hope that the bone heals before the metal fails. As we can see here, it can be bad failures. So if the fixation is not right, if you're not following the principles, unfortunately, bad things can happen. So just I wanted to have a quick chat about one interesting case just to challenge everyone. So this was a case 2 years back. I had this chap, remember when we put the unhappy hip? So this chap was 89 years old chap. And actually someone was following him in the clinic. And this was his latest x-ray before presenting. As we can see, it's obvious this hip is not a very happy hip. And this is the whole picture of his hip. So we can see both sides, how they were. And just to add to the pleasure, we have a small implant coming further down from the right side. And this patient has a revision. Sorry for the glare in the pictures. This patient had a revision knee on the same side as well. And then this patient presented with that. Great case, 89 years old chap, very frail, having this hip, this knee with a great bone stock, and it snapped in the middle. Any suggestions, Dr. Muhammad? So any suggestions? What? And again, non-operative, unless the patient will die on the table, is not an option. So because they will die on bed. So if we're gonna do something, Dr. Muhammad, this is, like I said, I said a case at the end just to refresh everyone.
Yeah,
so,
this is one of the disastrous cases, sir.
Well, I have to say, it was a one-off. And like I said, I thought just of sharing it with everyone. So, like I said, very little bone, and this is what we get. So the option in such cases, what we went for is a mega prosthesis. So we went for a total femur replacement.
Yeah.
So as we can see, even we tried to leave some bone here, again for the GT, and the whole femur out. What we did in this case, again, we didn't want to do much with the knee. We had enough with the femur, so we didn't want to do much in the knee. So this knee revision was a Zimmer one. So we called the Zimmer company and we asked for their total femur to match what we have on the knee side. So, and this is the implant. That's the approach. It's a big, brutal surgery. I won't say it's just a light one. And this is just everything comes out and we have it done. So just a quick in summary, periprosthetic fractures are on the rise. We are doing more hips now. So you would expect more fractures. They cause high morbidity and mortality. I would advise MDT approach for these ones. They are not easy ones. So between yourself, I would easily ask another colleague about opinion, and even in very good occasions, actually, it's a two-consultant job that to go in. Some of these ones are really complex ones. Happy versus unhappy, it's always good to know the history of the implant which was in. Take a detailed history of the procedure, what happened from the start, any adverse problems, any pain, any wound problems. Again, just like the normal workout of a hip. It needs a trauma and revision arthroplasty skills. I mean, again, this is not an easy case. Non-operative treatment leads to unfavorable outcome. Again, if the patient is unfit, fair enough, but otherwise, no. The plate has to be sturdy, and please try to avoid stress risers spanning the femur as high, low as you can. Revision, if we're gonna revise with an implant, the stem, it has to at least bypass the fracture by 2 cortices. And always remember, it's a race between the union and metal failure. Thank you all. This is just a picture from the operating room. So just the view from there.
Thank you so much, Dr. Amr, for this very interesting presentation. بصراحة presentation رائع دكتور عمرو وجمع كل حاجة.
Well, I try just to get it to the point, Dr. Muhammad, and try to avoid all the lots of theory in the books. And I know that we can all read it from the books. I just wanted just to get things, well, I thought relevant and to the point.
الصورة دي شبه لوخ لوموند أو لوخ ناس مش كده يا فندم؟
Actually, Loch Lomond just crossed me. I have a clinic in Loch Lomond actually, so I do clinic there a week in Loch Lomond.
Yes,
which, by the way, Loch Lomond is the city of Loch Lomond is
yes, it's very beautiful.
Alexandria. So it happened. I end up in Alexandria at the end. So.
أنا عشان كده لما نزلت عنوان المحاضرة يا فندم لقيت كل أساتذتنا في اسكندرية بيشجعوا على الفيس، فقلت الله مؤكد الدكتور عمرو من اسكندرية أصلا.
أقول لك اسكندرية الحمد لله سبحان الله. I end up in Alexandria at the end, but very north in Scotland.
Yes, sir. I have 2 questions for you, sir. For me, and then we have questions. First of all, حضرتك جاوبت على السؤال اللي أنا كنت عايز اللي أنا كنت عايز أسأل حضرتك عليه. اللي هو when I have to do proximal femoral replacement or total femoral replacement, and have you met such like cases؟ وحضرتك فعلا جبت الكيس اللي هي فعلا دي كانت ideal ل total femoral replacement. Now some cases you have severe osteoporosis, you have to go to proximal femoral replacement.
Yeah, I agree. So proximal femoral replacement, and as you know, well, it's not just the easiest one, just to chop it off and put it in. Actually, if anything, I would say maybe distal femoral replacement. I would say I would prefer to proximal femoral replacement. Well, both of them are high morbid, but if anything, the distal is slightly more functioning. The proximal one is quite tricky. It's very tricky because of all the soft tissues you have in the proximal part of the femur. And that's not the case distally. So proximal femur is quite challenging. 2 things. First of all, the bone, the muscles there. And, well, just a quick thing just to explain. So the interface between the prosthesis and the bone. This is a nuisance happening with all the implants at the moment because, sorry for the time, I just want to...
No, not a problem.
So this area here, so it's very, it doesn't unite. So how would you get this to fit to that? So you can either use the cement, but again, the cement will not gonna attach it there. So this area, and that's hydroxyapatite now. So lots of designs are happening now just to promote the healing between or attachment, in-growth, on-growth between the bone. So again, proximal femoral replacement, it looks like a solution, but no, it's got high morbidity, not to mention the expense as well. As we saw, the expense without this so the expenses that we mentioned actually pretty much without mega prosthesis. So 15 to 30, well, if you imagine 15 to 30,000 pounds to treat. So well, in Egyptian pound, this is $500,000 to $1 million for one case.
Yeah.
So it's a lot. It is a lot.
Yeah. Yeah. My second question, sir, for the multi-roof plate. I have attended a workshop in Barcelona arranged by Effort and AO about the كان لسه في بداية الإيرا of multi-row 3-row plate for fixation of periprosthetic fractures. Do you prefer to use this kind of plate, sir? Yeah, this one.
Absolutely. NCB, my favorite. This one, my favorite plate.
Yeah.
So Axis is the common one. It's common because, again, usually the way it runs in here, you have a deal with the company. So you get all the things from the company. But just to keep in mind, though, for example, where I work, we use Stryker. When I have a periprosthetic, I get NCB. And I have the Axis on the shelf. I prefer still NCB. The one on the right, the DeepWee one, this is a relatively new one. I have to say, I haven't used it myself yet. So I think it came on the market over the last 2-3 years, as far as I know. But like I said, I haven't used it myself yet. I use the Axis mainly for distal femur, and NCB, whenever I have the chance, I'll prefer to use the NCB. It's very strong.
Yeah, I have attended the workshop for NCP when it was at the start. It was in Barcelona about maybe 10 years or more ago.
It's
a very nice
how
plate.
was it? Sorry?
A workshop arranged by Zemar and arranged by Effort in Barcelona about the periprosthetic fractures using the NCP plate.
And I believe it might be even one of the first ones that came on the market, actually, because even the Axis, or no, they were not there. The NCB was there. We were slightly limited at the beginning because of the price. It's quite an expensive plate. I'm not quite sure now how much they cut it down. But again, if use the right tool, that's very important. Well, you cannot do half a job. So half a job is not a job, because when this fails, well, it's even going to be harder now. So I would say get it right the first time.
Yes, sir. We have 2 questions from our dear attendees. The first question, do you always have to do revision arthroplasty when there is a PPF? When to do revision and when not to do?
Well, no, like I said, I don't do it all the time. So as we mentioned, well, the good example of happy, unhappy hip. So if you have a happy hip, why touch it? So it's already a happy one. So the hip the hip is well fixed, and the patient did not complain before. No signs in the history or clinical examination or of septic or aseptic loosening. Just leave it and fix it. So actually the question is, so what, and like I mentioned in the middle, the B2s. So the B2s, we got a good bone stock, but the implant is not stable. So ideally, by the book, the classic teaching for these ones, revise. That's the classic teaching. But now, like I said, I came across few surgeons, people now considering for selected patients for these ones to fix. Again, just because of the morbidity. If you have to revise everything, well, we all know it's not easy. It takes long time, complications, blood loss. So do we really need that? Especially if the patient is low demand, doesn't do much. So that's in. Go in, do the least is best for the patient and get out. So again, just to make it clear, so Vancouver A, GTLT, no revision. So Vancouver B1, no revision, just fixing. B2, classically, and my recommendation will be revision plus minus fixing if required. Vancouver B3 will be revision plus minus fixation. Most likely it will need something on top of it. And keep in mind the mega prosthesis if they are available, and C is only fixing.
Yeah.
I hope this is clear.
Yeah. That's good. The second question, I think this is all our questions because we are not get accustomed to such prosthesis. What's the success rate of mega prosthesis of knee with hip arthroplasty? معظمنا فعلا مش
well, good question, but as you would imagine, so these, well, I couldn't find anything at the moment in the mega prosthesis that are used either for these such cases, or to be honest, more common, they're used in malignancy, in cancer. So this is where we got them mainly from the cancer, well, the oncology team.
It's a tumor prosthesis, sir.
It's a tumor prosthesis, exactly.
Yeah.
It's a tumor prosthesis. We're just reusing it in a different way. So already these patients, well, they are not the best cohort to see the long out term. I couldn't find anything. I didn't come across anything recent telling us outcome of megaprosthesis in periprosthetic fractures. Again, keep in mind, this is even in this category of periprosthetic fracture, it's a very few patients will end up having a megaprosthesis.
Yes.
Not the case, for example, in revisions. Well, it's more common in revision of a hip. So a revision of a hip, more common to use a megaprosthesis than the periprosthetic fractures.
Yes, sir. Any other questions, my dear attendees, my dear colleagues? I think we don't have any other questions, Dr. Amr. We have another question. Yeah, just thank you. Yeah,
no, that's fine.
Thank you. شكرا جزيلا دكتور عمرو بيه يعني for sharing your experience with us this very beautiful night. Thank you so much, sir. واحنا مقدرين جدا مشاركة حضرتك معنا يا دكتور عمرو.
I'm pleasured and honored to be with you guys. الحمد لله، يعني حاجة شرف ليا بصراحة ان انا اكون معاكم، وانا يعني سعيد جدا، واتمنى ان هو يكون في فرص تانية ان شاء الله، والموضوع باذن الله
ان شاء الله. احنا ده السنة الثالثة لنا في الكورس، احنا بقى 3 سنين في اونلاين في الكورس، والحمد لله رب العالمين. يعني joining يعني guest stars from all around the world، من اول اليابان والصين والهند لحد البرازيل وكندا وامريكا، وطبعا كل اوروبا كانوا معانا في الكورس الحمد لله. فده بفضل الله سبحانه وتعالى وبتوفيقه، ثم بمشاركه حضراتكم يا فندم.
والحمد لله، وهو برضو مجهود حضرتك برضو لازم، لان هو الكلام ده من غير الكلام ده احنا عارفين it's not easy to arrange، يعني الكلام ده كله، فلازم برضو نشكر حضرتك على المجهود والوقت اللي حضرتك بتقضيه في هذا الموضوع.
سعداء بتشريف حضرتك معانا، وان شاء الله احنا عندنا مفاجاه الاسبوع الجاي. عندنا 2 eminent stars من الاي او، بروفيسور سفيان القلال من تونس مع بروفيسور اسامه فاروق من مصر، هنتكلم على injuries around the knee برضه. فيعني ان شاء الله هيبقى يوم علمي جميل ان شاء الله يا فندم.
ان شاء الله، يبقى ان شاء الله we join next week ان شاء الله.
ان شاء الله، يعني ان شاء الله نسعد برؤيه حضرتك سواء في مصر او في انجلترا دكتور عمرو بيه.
باذن الله، واكيد ان شاء الله اي فرصه حضرتك تشرف اي حاجه قريب كده حضرتك باذن الله نتقابل باذن الله.
شكرا جزيلا يا فندم، شكرا جزيلا يا فندم.
وحب اشكر كل الناس اللي حضرت. ثانك يو.
شكرا جزيلا يا فندم، شاكرين. شكرا اخواننا في الحضور، our eminent speaker and our dear attendees and dear colleagues, and see you next Friday ان شاء الله. شكرا جزيلا يا فندم. شكرا جزيلا. السلام عليكم. الله يبارك.
وعليكم السلام.